We have 2 live cases coming up. GB Pant Hospital. You can see Dr. Balbir Singh. Hello, Dr. Balbir Singh. Can you hear us?
Yeah, can you hear me?
Yes, sir. We can hear you.
So we have the case ready for you. Okay. So I am in GB Pant Hospital and it's a great privilege for me to be here. This is the campus where I did my MBBS, MD and DM all together. And I am joined by Dr. Sanjeev Kathuria, who's the assistant professor in GB Pant. So I have a very elegant team to support me and a very challenging and a difficult case to start with. So we'll have the case presented to you first, and then we can have, and then we have the opinion of the panel, and then I go ahead and show what we are doing.
Any other slide? Basically, good afternoon everybody. This is a 58-year female, known case of diabetes. She presented to us with
The voice is not
ECG,
loud enough.
Some dynamic. This is a 58-year female, diabetic female.
Can you speak up because we can't hear you?
Just the speaker.
So I'm going to tell what Sanjeev is going to telling me, that it's a 58-year-old diabetic. She looks older to me than what is mentioned. She's a 58-year-old. History of ACS and inferior MI in the past, and her ejection fraction is 45% with regional wall motion abnormalities in the inferior territory. So we are going to show you the angio images, and then we have a discussion on that. Can we show the?
Can we go to the slide?
So are you seeing the angio?
Yes.
Have you seen the left shots?
Yes, there is only one shot which we are seeing repeatedly, which shows
So this is
circumflex and.
so this is the RCA.
Yeah. Now we can see the other shots.
Can we see the RCA?
Yeah, so we'll show you the RCA now.
Basically, she has a left main trifurcating with a long segment disease in ramus, LAD as well as the LCX, and she has a CT of the right coronary artery. And we started with the right coronary artery considering that she had an old inferior wall MI with ejection fraction of 45%.
So can you see the guiding shot, the RCA?
Yes, we can see the shot. Now, what is the plan in this case? When she is diabetic, she has a severe triple vessel disease. That is what we could get till now.
Yeah.
What is the plan?
So the plan was, the patient has refused surgical option. So we can have a discussion on surgical versus stenting, but looking at the multivessel disease, long segment RCA, long segment LAD, 2 lesions in circumflex, 1 in the ramus. Both the options can be considered. So the patient is not willing for a surgical option. So the question was to revascularize. So what was the best strategy to revascularize? I will show you that our thoughts was that since RCA is infarcted, there are some collaterals from the left system. I'm going to attempt the RCA, but I'm not very going to be very hard because it's very thin and you can see a very long segment of stenosis. And it is a CTO and the proximal part. So we got the first wire. Next shot, please.
Next shot.
Which is a filter XT wire. It won't translate beyond that. So it was backing out the guiding catheter. So at present I have changed to Amplatz right and trying to recross this lesion. So my plan is if I'm not able to cross in the next 10 minutes, I will give it up and go to the left side. It's an infarcted region and vessel is really very thin for making too many efforts to get a good result.
Are you using
I would open it
any,
to the panel to have their thoughts.
using any support devices like microcatheters? Because this is a vessel that has a lot of disease and tortuous, so you need support with a guide and you need some accessory devices. Probably microcatheter will help you to cross.
Right.
Pure wire alone
So
would
we
not be
are now
successful.
changing the guiding catheter. Right, I agree with you. We have changed to an Amplatz guiding and I'm now taking a microcatheter with the guiding catheter. So that's the only way I will be able to get it.
Take a strike.
So any differences in opinion about the strategy or the panel has some different thoughts?
Well, I think this patient with LV dysfunction and severe multivessel coronary artery disease, the question of revascularization should be addressed more diligently with the patient regarding surgical revascularization. However, if you decide to go with non-surgical revascularization, I think you should achieve complete revascularization to have the most benefit, including a good trial of RCA revascularization using microcatheters, different wire, different supports. Otherwise, this patient will be denied the long-term benefit of revascularization or some of the long-term benefit of revascularization.
Absolutely. And considering that she is diabetic and she has small vessels, long-term results are expectedly not so good, particularly in this case. But as the case has patient has refused surgery, probably we have no other option. But this right coronary, I think, Dr. Balbir, I would like to ask one question. How long you are going to try? And if, should you succeed with right, are you going to do all the three vessels in the same sitting?
No, if I succeed with the right and how much time I took, I would just do the LAD. And depends on the contrast that has been used, or maybe just leave it to the right and get the patient for a stage procedure next time. But I have a difference of opinion. This right is infarcted and there are some collaterals feeding this artery. So if we can do a good job on LAD, LCX and Ramus, we will get a good long-term result, because it is not, even the surgeon is not going to get a great graft on this right coronary artery.
And what should be your plan for the left system? Should we not succeed with right and we go on to the left? We are planning to put 3 stents, one in the ramus, one in the circumflex and one in the...
So I'm trying to think of 4.
Okay, the mid-circumflex
Circumflex
lesion.
has 2 lesions.
Circumflex, middle circumflex lesion also needs...
The 2 stents.
right.
Circumflex has a lesion after the OM and before the OM.
Yeah.
I mean, going back to the size
So
of
I'm
the
getting a
vessel.
microcatheter.
Yeah. Size of the vessel is not really determined from the first angiogram. When you have subtotal occlusion, a lot of these vessels, they expand beyond what you see initially on angiograms. So to label a vessel as a small vessel because it has a total occlusion or subtotal occlusion is probably underestimation of the true size of the vessel. Once you revascularize the vessel and give some vasodilators, you will end up with a much larger vessel than you see on the initial angiogram. Do you see that? Or you see that most of the time?
I would agree with that.
And circumflex is not a very big
But
vessel.
the issue again is that, no, if you see the circumflex is a co-dominant system. If you see aleocranial, There's a PDA coming from the circumflex as well.
Oh.
What wire you are using at this time?
Which is this wire?
This time I'm using a whisper wire. I'm limited by the number of wires that are available for CTO. I wanted to use probably a Gaia wire at this point.
Do you think it's fair to say once you want to do a CTO, you have to be prepared with all the equipment from wires, devices, and so forth? Otherwise, your success rate will be limited. And so in our strategy, once we want to do a CTO, we have to have all the equipment available because you don't know when you're going to be successful and which wire will going to be leading you to the perfect results.
Check. Small check.
Is there any way we can improve the image quality of the angiogram?
And there is another reason why if patient refuses surgery, I would like to go for the left system is that we can follow up and get back to the RCA later on also.
So is there a micro catheter also, or is it the only wire? Because we can't see.
Yeah, there's a microcatheter. This is a microcatheter. It's still in the guiding catheter. I'm just trying to get across the branch.
If you advance your microcatheter further, that will help you a lot. It's going to be leading
Yeah, I know.
just
I
behind.
can understand what you're saying. Yes.
While you're working, can you give us an idea about the antiplatelet regimen that you have done for this patient?
Yeah, she's on aspirin. Yeah, she's on aspirin and clopidogrel.
And we had a good discussion before about the use of antiplatelets in acute coronary syndrome, and this patient seems to have an unstable angina. Do you have any preference, or this is what is available?
So the ticagrelol should have been the choice, but she's already loaded with clopidogrel, so I didn't disturb it. Next. Yes.
Do you have another case lined up in other lab? Because the brochure says there are two cases.
Yeah, we have. So,
In the meantime, we can switch over to the
so
other lab.
you can go to the other lab.
Yeah.
Yeah.
Okay, we are back to you once again.
Okay. So I switched back to the field XT wire. I do not have too many choices of wires here, so if this doesn't go, I will switch to the left side. ठीक है.
Deep. Test. Deeply into it.
Test.
Someone to look after, there is no voice. The second lab is not getting connected. Ask them to have it.
Test.
They're trying.
Two 2.5 order.
2.4.
Can we try one more time to move to the second cath lab?
They are trying to set the audio
So
right.
I have been able to make.
So we are back to cath lab number 1.
Yeah, so I'm here. Can you hear me?
Yes, yes, we can hear you. What is the status?
So I left you here I left you at this site. Can we go to the next? So we took a implants and a micro catheter and made some progress. Next. And crossed it. But I had a 1.2 into 6 millimeter balloon. It did not cross the proximal lesion. With a guiding which was reasonably good support. As you see from the left side, there's a lot of calcium in these vessels. So it was highly fibrotic, and a 1.25 into 6 legend balloon did not cross the proximal lesion. I didn't have any other further techniques to help get my balloon across. So I think we leave it for the second sitting, and we went for the left side. Next, left. So then we went for the LED, and you can see a long lesion. Next. This is so the diagonal is not from the site of the lesion. There are a couple of septals there. Next. We dilated, made a good bed, and there was a waste at this point which went at a high pressure. This was a 2.5 millimeter balloon. Next. Took a long stent, which is a 3 into 34 ONAX. Next. Next. This is a good deployment at 12 atmospheres. Next. Next. Post-dilated it. Next. Next. Back. So this is where we are now. So we have achieved a great result on the LED. We can show you the last picture here. And we proceed to the circumflex. So if you see the collateral to that PDA, it's pretty good. So I'm going to leave that RC as of now, and with better hardware later on, it can be attempted again. The good thing was that we were able to cross it very well with a fielded XT wire. The balloon didn't cross, so maybe next time a bigger support or a Tornus catheter or a 1 millimeter balloon may achieve that result.
Great. What's your next step now?
So I'm going to the circumflex.
Okay, great.
What would you have done in that situation where the balloon didn't cross? Would you have pursued, or would you have moved on like I moved on?
I think that's also a good strategy to move on to the left. Now, circumflex, you are planning to put 2 stents, right? That is what we, or a single.
Yeah, right. Yeah.
2 stents.
No, I want to put 2 stents. I want to avoid jailing that OM.
Yeah.
And 1 stent, I think 48 can only cross, and there's a lot of calcium. I don't want to get into that trouble. Branch hand. Test.
There's a lot of calcium, which is an important determinant factor to use a single stent.
I want just to go back on the right coronary artery. Few tricks that can help you to cross with a balloon. One of them, guide liner, if you have it. The second one, using a second wire just to direct you with a calcium. It can just redirect the balloon and can help you also.
So I tried a second wire, which was it didn't cross.
Do you have guide liner? Sometimes that can be helpful to give you some extra support.
So now I want you to view that ariocaudal and look at the ramus. Do you think it's worth doing? Just look at the vessel size. Can we show the ariocaudal projection?
I think we should leave it on medical management. That ramus is a long, diffuse, small vessel disease.
Yeah.
It is better left with medical
Yeah,
management.
so that's what I thought. This one.
I'd leave it for medical disease. Do you consider that the distal circumflex significant? I'm not sure if you're just doing a stenting of the proximal circumflex would be enough in this case.
Initially, I also thought it was a moderate lesion, but then either you...
Can we show the left circumflex?
We show it again. You know, to me it appears significant.
Does look about 70%.
Particularly with the fact that this OM is one of the biggest. Yeah. So this OM is very big and feeding collaterals to the PDA.
Because once you go beyond the marginal, the vessel is diffusely diseased. So I may consider just treating the proximal segment and leave the distal segment on medical therapy also.
D8 system?
10.
The mid circumflex lesion does look about 70% or so.
Down. Test. So. Go up. So 10, 12, 14.
So what is the size of this balloon? 2 millimeter? Dr. Balbir?
This is a 2 millimeter.
Right.
2 millimeter.
Yeah.
2.5 I thought wouldn't have crossed it. 2 millimeter also went with little difficulty. 16. 2.5 chahiye balloon.
2.5 please. 16.
Down.
Five, please.
So what is the,
Take a 2.522 on X.
what stent and size you're contemplating?
So I'm taking a 2.5 into 22, 22 into the distal vessel, and proximally I'll see again after dilatation. So we can measure it here, right here. Oh,
No problem.
Okay.
A little bit, yeah.
so this is a 12 millimeter balloon. So we could do with an 18.
Yeah. Should I go?
Go. 10.
Done.
Down. 10. Down. Test.
Yeah.
10.
Done.
Down. 10.
Done.
Down.
Dr. Balbir, we have couple of minutes left
0.518.
for the transmission time. Another 3-4 minutes. If you could show us the distal circumflex
Ready?
stent.
So I'm going to use the stent.
That is
Yeah, I'll
2.5
show
by 18.
Sure, sure.
Is that correct? 2.5
Right.
18?
Right, that's right.
Yeah.
Yes.
Yes.
So fortunately, even though there was calcium, but we could get away with high pressure in the LED and the circumflex as well.
Leaving unprepared.
Okay, go.
Yeah. Should I go up?
12,
12,
14.
14.
So this is well expanded. Down.
Picture.
So I may use a longer stent for the proximal part. We see just post-osteal, there's a small dissection, and I'll use a
22?
22, 2.75, 22.
Can you repeat what size stent did you use?
I use the 2.518 for the distal part, and for the proximal part, I'm taking a 2.75 into 22. I will start at the post-osteal region and go up to that OM.
Yeah.
And just explain to me why not using one stent to cover the whole segment from the beginning, since it's covered by.
I
30.
had a feeling that, yes, you were right, that I didn't have a 48 millimeter, so I didn't think that anything shorter than that would have helped.
Okay.
And the second part was there's a lot of calcium. It would have given me some friction getting the stent down.
Leaving back.
We might end up gelling the obtuse marginal.
Let me see. That looks okay. Would you agree with that? Yeah, go up. Yes. 10,
Done.
12,
Done.
14,
Done.
down. 3 ka balloon,
Three ka balloon and see.
and see. यहाँ पड़ा हुआ है हमारे पास.
This was 2.75 by 22, right?
Yes,
Yeah.
right.
Yeah.
So I'm going to post-dilate the proximal stent. Looks good.
Yeah, it looks good. So the time is almost over. Thank you, Dr. Balbir. Well, it was an excellent demonstration of.
Yeah, thanks a lot.
Yeah. Well, we had great cases today. Thank you very much. And we hand over the mic to the organizers for the next session. Thank you very much once again.
Thank you.